I'd especially like to welcome all to today's webinar titled The Latest Developments in Biological Treatment in Cartilage Repair. I'd also like to welcome our panel and presenters today. I would also importantly like to welcome participants from Hong Kong, the US, Singapore, New Zealand and Australia, and the UK, of course. For those who don't know me, my name is Paul Addison. I'm the CEO of a company called Orthocell. We're delighted to host today's webinar. For those who are also unaware, Orthocell is a regenerative medicine company. We work in the area of providing cellular therapies and regenerative medicine approaches for the repair of articular cartilage, tendon and bone. Our product, autologous chondrocyte implantation here in Australia, has recently been added onto the ARTG here in Australia. We've got three great speakers today, covering different aspects of cartilage repair, including the scientific aspects, the clinical aspects and the rehab aspects, three key components to any successful cartilage regeneration process or understanding of cartilage injuries. All of these speakers today have significant experience globally, with global reputations in adding to the global learnings of cartilage repair. And so we're delighted to have these three esteemed guests with us today. We know that ACI is a well-established technology. We know that the evolution came from Lars Peterson and Mats Brittberg back in the late 90s out of Sweden. And we've seen in recent times ACI approved for use in the UK by NICE. It's received its first FDA approval. And of course, as I just mentioned, is now the first cellular therapy for cartilage repair approved in the Australian regulatory environment. We also know that there's multiple long-term randomised data around this study, and I think we're going to hear from one of the presenters, Jay, later around some of that randomised data. And really ACI is regarded, because of that data, as the gold standard for cartilage repair isolated chondral lesions. We also know that there's a growing understanding that perhaps microfracture can have a deleterious effect on the subchondral bone bed, and also a growing understanding that cartilage is a unit. It includes the cartilage, the subchondral area and the chondral bone bed. And so really the conclusions we've come to in this space globally is that if you have the right patient, the right implant, meaning the right cells and the right surgical technique, the right rehab, then invariably you have the right outcome that adds to patients' activities of daily living and their successful outcomes from ACI. So without further ado, I'd like to invite Professor Ming Zheng to present the first today. And Prof. Zheng is a professor from the University of Western Australia. He's completed PhD, Doctor of Medicine, and is a member of the Royal College of Pathologists and the Australian College. He's also currently a member of the Faculty 1000 Prime, a very esteemed group, and is Associate Editor of Stem Cell Research and Therapy. Prof. Zheng really is proven to be a global leader in the field of regeneration of tendon and cartilage using the patient's own stem cells. He also pioneered the development of collagen-based medical scaffolds and cell therapies to treat cartilage and tendon and ligament injuries. And his work in giant cell tumour for the bone has been used by the WHO for official classification of bone tumours, so quite some significant body of work. Prof. Zheng is a full professor from the University of Western Australia, and in addition to his academic endeavours, he's also the co-founder of several patents that have now been translated into clinical practice, including the Macy product in the US. So without further ado, I'll just ask Prof. Zheng to put your presentation on slide view, and we'll get started. Thanks very much.
Thank you, Paul. Good evening and good afternoon, everyone. Thank you for coming to this webinars. I just like to start by sharing the information with you on the histology. Sorry. On the histology of osteochondral structures. As we all know that cartilage and bone are joining together as an osteochondral unit. When you look at this structure, the cartilage itself got the elasticity while the bone got certain compression force. But in the junctions, it's very important. They're joining together by formulate a number of the structures, including thyma, calcified cartilage, cement line, and the subchondral plate. So together with this cartilage and bone structures, the unit that they form are unique for the joint motions. When you look at the development of osteoarthritis, the first change that we have seen is the change of the cartilage and bone interface, which we normally see in the histopathology. There's a double thyma and the change of the cement line. And in particular, where the cartilage has been wear off, we see a lot of change of the subchondral bone structures, including subchondral bone sclerosis and also subchondral bone cyst formation. And sometimes you can see very active bone remodeling and the synovial fluid coming from the joint actually leaking into the subchondral bed to activate bone resorptions. Recently, we have published a paper in rheumatoid in ARD showing in the BMJ journal, showing that an interesting phenomenon is that in some of the OA patients, we see the separation of the cartilage and subchondral bone with a pathology called horizontal fissures. And in that, the synovial fluid come inside and eroding the cartilage away to induce the cartilage eruptions, not only on the surface, but also of the subchondral bone interface. So here is a cartoon of showing that how OA being developed. First, you go to the wear of the cartilage and the change of the subchondral bone. And then you start to see a lot of subchondral bone remodeling heading to the end, and the erosion of the cartilage, or the cartilage disappear, and there's a severe subchondral bone pathology that I described. About 30 years ago, Max Breitbart published a paper in New England Journal of Medicine showing that we maybe can introduce a regenerating technology to heal the cartilage to stop the progression of osteoarthritis. So what Max Breitbart been doing is by taking a principle that the cartilage cannot regenerate by itself. Instead, he took the biopsy of the patients on cartilage, grow those cells, and inject this chondrocyte back to the cartilage where the defect is occurred. And then he took the periosteal membrane to cover on the surface. This technology in 90s attract a lot of attention, but the complication is, of course, when the cartilage grow inside the joint, the periosteums also grow. So it induces the hypertrophy of the graft. We take the liberty of advanced Max Breitbart's technology by replacing the use of periosteal membrane with a callosal membrane. So in that case, we actually minimize the surgery by integrate the cells with the callosal membrane for the cartilage transplant. At least similar technology, other similar technology has been developed, but this has been seen as a second generation cartilage repair technology. And normally this is the cartoon to show that it took up to 6 months for the cells to infill of the osteochondral defect. So today, this cartilage technology, people using many different names, but MACI is the most easy name to be mentioned, but actually it's evolving from our patent in 2000 that we developed this, what we call the cells on support matrix for tissue repair. And as a result, we're using the wording of metric. It has been, MACI was evolving from what the term called metric, induce or assist autologous chondrocyte implantations. And FDA to think that have to be bordering the technology by introduce the actual meaningful term. So FDA introduced this autologous cellulized collagen scaffold implant as a first technology. But later on, Max Wigbers, the father of this technology, he said, well, this is probably called metric applied cellular therapies. In Australia, because it changed a different company, so currently MACI has been used as a name as a called Osteoarthritis ACI. So when you look at the evolution of this technology, it's about 20 years of the history of this metric assist chondrocyte implantation. Our first publication from Australia was actually around 2005, 2006, and took about 10 years, more than 10 years for FDA to finalize the technology and gain the approval in United States for the use of the treatment of osteochondral defects. Here is some of the news coming out. Interestingly, I just got it a few days ago in United States. They talk about that instead of a total knee replacement, surgeon now can using the cutting edge cartilage technology. Its name is MACI for repair of the joint. And when we look at this technology, I saw way in Australia is probably 15 years ahead of US in terms of MACI development. So what we have now of this also ACI technology is that we will further develop this by integrating the cells with the collagen scaffold in the theater rather than in the laboratory. So let's make it more friendly, user-friendly. So it's a graph that you can use after loading the cells. You can see these chondrocytes actually will integrate with the collagen scaffold. And this collagen scaffold is a porous structures that can hosting more than 10 million cells. So as a result, you act as a delivery systems. The ideal MACI itself, it can regenerate the cartilage and will integrate with the native cartilage tissues. And the MACI graft itself is always characterized by high cell density as compared to the native cartilage. And most importantly, a good MACI graft is well integrated with the subchondral bone plate and forming a good structures. And normally we will not see a lot of subchondral bone pathologies. And this chondrocyte is we see regenerate a highlight-like cartilage matrix. Even for some of the patients that have the MACI and in the end, it going through the total knee replacement, the MACI graft itself is always far better than the surrounding cartilage tissue in terms of the histology feature as well as the biomechanical features. Study from Europe has also confirmed the MACI technology that were developed in Australia. This is a typical some of the study as a highlight here, but say from Germany showing that when they compare MACI with the microfractures for 2 years study outcome in the randomized control manners, you can see MACI itself is far more superior than microfracture itself in terms of the functional outcomes. One of the pivotal study that actually make FDA to approve this technology and abandon the microfractures is this what I call the SUMMIT study that conduct in Europe. It's a team, a cohort, the SUMMIT team that compare microfractures with MACI by itself, and then they run from 2 years to 5 years of the randomized control study in over 70 patients per group. And the result is showing that if generally is in over 6 months when the MESI look good, over 2 years to up to 5 years, the outcome is always superior than the microfracture by itself. And this is not just for the functional outcome, it's also for the structural repairs. So the result of showing this metric-based autologous chondrocyte implantation, instead we call MESI as a trademark, is a good technology for cartilage repair. It's far better than microfractures. In Australia now, we even now further develop of this technology, because in Australia regulation, we can cryopreserve these patients' autologous chondrocyte for up to 25 years or even longer. And as a result, we're giving patient a time for actually doing MESI of deformed stage to delay the total knee replacement. And this is an example that by Dr. Ray Crow in Melbourne, like a patient has a MESI graft 4 years ago, and because the condition is further progress, and there's another ulceration next to this MESI graft, and the rest of the joint condition is actually fine, and as a result, we're able to conduct the second MESI without a biopsy. So it's become a one-stage procedures. So MESI is a very encouraging and is good for cartilage repair. At the same time, we do have some patient that is not happy and in the end had to do a total knee replacement. And we do have some other patient that have other conditions, not just the cartilage injury and defect. They also need to do have a revision surgery for other conditions. So we being fortunate as referral centers in Australia for all these MESI graft for the assessment of the histopathology of their outcome. So we're able to compare the revision, the surgery, as well as the total joint arthroplasty patients on their MESI graft. The real take-home message up here is that when you look at the total knee replacement patient with the revision patient, their age group is very, very different, but the size of the defect is very similar. In actual fact, the revision surgery, the younger group patient, the defect size are much relatively larger than those patients with a total knee replacement. But the interesting things out here is that when the patient undergo total joint arthroplasty, the MESI graft itself is technically okay, but most of the time what we see is the subchondral bone pathology. It's severe subchondral bone sclerosis and bone cyst formation. This is a bone cyst formation. You can see here the bone cyst formation. When you compare the revision surgery, which is the cold biopsy, the MESI graft itself is very good. It's highlighted like cartilage. But when we also compare the anatomical side of those revision surgery graft of MESI, we found that the ankle itself got a very good outcome. Most of them is a highlight like cartilage as compared to the knee sides. So this also somehow indicate that ankle have got less osteoarthritic condition as compared to the knee joints. But in general, what we see is that the failed MESI pathology up here is not mainly due to the MESI graft itself. It's due to the subchondral bone change, like similar to what we see in osteoarthritis condition. And here I just show you some of the study that we've done on the end stage osteoarthritis condition. It's typical, like when you look at it where there's no cartilage, we see a severe bone cyst formation, bone remodeling, and subchondral bone sclerosis. And we also see the horizontal fissures between the cartilage and subchondral bone. And this in particular, in a patient with obesity, we can see a lot of this pathology up here. So just a simple cartoon here. Let's assume that it's a condition of osteoarthritis, talking from the early stage to the late stage, where you can see a lot of late stage change of cartilage wear off and severe subchondral bone cysts. But if we have see the cartilage lesion and cartilage defect in the early stage of the OA, we probably repair the MESI, using MESI to repair this very, very well, and we probably can delay the MESI, delay the total knee replacement to the further stage. But if we do a MESI at the very late stage, this is really what we have seen. We repair the cartilage, but the subchondral bone pathology still persists and still continue. And as a result, is what we see up here is a MESI. We just regenerate the cartilage. We still cannot regenerate the joint. So my take-home message out here is that MESI should be treated for the patient with the early stage OA, but the very late stage, we maybe ask for too much. But on the same time, if we can dealing with the subchondral bone pathology and other inflammatory condition in the joint, maybe MESI is still a good technology. So with this, I just have a take-home message out here, a direct quoting of what Max Weber's been saying in 2018, the metric-based cell therapy, that's including all these collagen loading cell technology, is that can improve surgical handling, increase patients' comforts around for expanded indication with a better reliability within the knee joints. And MESI, to our knowledge, is the only technology that can restore a tissue that is very close to articular cartilage. The failed MESI in the joint is due to the OA pathology. It's not really due to the graft itself. Thank you very much.